But I think it's really tough that we have to start a new class right after that neuro because it's such an ordeal to get to the end of it. But we're going to do it anyway, so we're going to get going. I'm going to try to be kind enough in how this module is run and organized so that you know what to do. So what we're going to do here in this first 30 minutes is really just orient to what we're going to be doing overall so that you at least understand what's the roadmap. And then we'll start moving into various parts of content. I'm going to have to give y'all a bunch of breaks in this day because I've got to get y'all to move around because I know that if we just go and you're out here and I turn these lights off, it is over. I mean, I know it'll be over. Well, Paul, it's kind of over for you any day. I'm so glad we have finally come to behavioral health because now we can talk about things that are real pertinent to you. You might be able to see yourself in some of these things. Okay, let me go ahead and get some of these things up. Okay. Your syllabus is posted on the D2L site. I have posted your syllabus and your course schedule. It should correspond to the calendar. I tried to keep all those things put together, so your Outlook calendar. So if you see any mismatches or have any questions, you have to let me know. I'm pretty good about responding in real time to things like that, and I do encourage you to do it. So we have schedule and syllabus up. I've also posted the content for depressive disorders, and I'll be putting in the information for bipolar disorders later tonight. I'm kind of looking at it, thinking if I want to do anything different with what I've got. But we'll have that up for you to look at. This class is, I wouldn't say it's a hard class. I wouldn't say it's an easy class either. I think it's a class with a lot of content. There's a lot that we will be covering here. We're going to be covering most of the major psychiatric disorders and behavioral disorders that you will run into as a practitioner. There's a lot of reason to understand this because you can get all involved with lungs and heart and kidneys, but all of those organs are in a person with a brain and they're acting different ways. And it may surprise you what you see in practice. In fact, I know it will. And no matter how much you are familiar with what patients can and cannot do or how they present themselves or come across, it's still somewhat kind of shocking and surprising at different times exactly how people act in a space when you're there as their provider. So hopefully this will help demystify some things and give you a lot more orientation to what things look like and how they might present. And all of it really, in terms of therapy and how you would manage it, they're all the first approaches. Most of these disorders are very difficult to manage. I think you have to have real clear endpoints. Your endpoints of normalcy, that if that's what you're seeking, may never actually come to be. You're moving things to a better place. So I think it's an interesting class, and I think you will learn a lot, and I think it will be helpful, particularly when you get out into practice and start encountering patients. Let's just look at the syllabus, and then we'll look at the schedule. And I'm not going to go all over the place here. We've got a few outside people who will be coming in to teach. This class is probably taught 40 to 50% in the house and about the other part outside. So this will have a preponderance of people inside this program. I teach a large amount of it. Dr. Latassi teaches some. And then we have some really good outside speakers as well to kind of give a little bit flavor for the whole thing. So I hope that will help. In a lot of ways, I think when you can bring the teaching in-house, you actually have a lot more predictable course. Okay, as y'all have seen as time goes by, and no offense to anybody, it's just harder to get a lot of people from outside to be on your wavelength, sufficient to learn the way you'd like to. So this course, as I said, it helps you begin to approach behavioral and psychiatric disorders. So always remember it's introductory. What we tell you is like the beginning, and there's just so much more. If you get into the area, you will learn a lot more than what we're going to present here, but this will certainly get you started. This class is a 2-week class, and it just falls at the worst possible time. I mean, I had thought that ever since it was laid down. You've got 4th of July in the middle of the week. Okay, that's a problem. Okay, we're not going to be here on the 4th of July. if that holiday had fallen any place else, if it had been Tuesday or Thursday, I'd have given you the day off and we'd have redone stuff so that you had a longer weekend to kind of actually have a break. But it falls in the worst possible time, so we have it in the middle of the week. I really can't not do stuff in the 2 days leading up to that, but what I am doing to kind of give a little bit of breath to the whole thing is we're not going to start class until Thursday afternoon. So if you are going somewhere or you're going out of town or you want to stay up late and do whatever you want to do, you don't have to get up and be back down here at the crack of dawn the next day. So it's small, but it's something, okay? Something we can do. So I hope you can at least appreciate that. I'm trying to give it to you. I really wanted to put a day with it. I thought a day with it would have been even nicer, but it's not in the cards. Okay, so don't get arrested. Please come back at 1 p.m. on Thursday. And the topic when you come back is schizophrenia. It's a real good topic to get into when you come back into the room, so we'll kind of pick it up and get going pretty fast. Okay. There's something else we're going to do in here. There are SP experiences built into this course, but it's not the classic SPBL that you have been doing, all along. And I wouldn't even say it's an SP experience like going in just to learn how to do a certain type of an exam, disconnected from a full SPBL type thing. But what we do is we teach motivational interviewing as it applies to sticky situations, difficult issues. And those motivation interviewing skills are useful for a lot more than just psychiatric disorders, way more. They are really what you're going to need to help bring about behavioral change in patients that you see regardless of what practice area you go into. You go into the room and you have whatever amount of time you have, and you are in no way in control of that patient. You're responsible for them, and there are things that you have to do, but they're mostly not around you. So what do they do when they go home? How do they live their life? What do they do? That's all about how they're going to have health. And you have to find ways to lead them in the right direction and keep helping them move towards health. And motivation interviewing will certainly do that. It allows you to open dialogues with patients about uncomfortable topics and help them change. So you're going to like it, but that's the second part of this week. Nothing to worry about this week. There's nothing to worry about. I'm telling you, it's just we're going to have our experiences with it, and I think you'll find it useful. There is no textbook for in here. All the stuff that you need will be given to you, but there are some sources you can look at. You can certainly look on your Access Medicine website, and I've got some things listed here, but I think we will have it packaged for you. I am very good about making very clear what I want you to know from outside speakers. So I will have learning objectives for every topic taught in here. If I do it myself, if somebody comes in from out here, I will have objectives developed for how I want you to know what they have presented as soon as is physically possible after they have done their talk. But I need to hear it before I can't submit them before I've heard it because I don't quite know how they're spinning stuff. So I want to see that. But I will be sending that out so that guides how you look at it. It doesn't release you from knowing stuff at some point down the road. I mean, you have to know things, but I don't care if you know every statistic in the table and nobody tells you if you have to know it or not. I mean, I just don't think that's a good use of brain, okay? So I will keep you very focused on what you need to know, so you'll know what you need to know. It'll just come down to whether you know it, and can bring it back up. So that piece will be happening all along, and that will guide your learning. Okay. You know your online resources. The course concentrations, there are not a chunk of concentrations in this course. Clinical medicine is the big one, just describing, identifying, and knowing how to make a diagnosis of a psychiatric disorder or behavioral disorder, that's in there. So that'll all be clinical medicine. There is some pathophysiology as much as we know about these disorders. If anybody has spent time working with psychiatric disorders or behavioral disorders, it's not really well known why things are like that. You know, we're so used to teaching you in all these other diseases what's going wrong at a cellular level, and we know a lot of stuff about psychiatry, but we just don't know everything. It's more of a mystery box in some cases. So it's more about just seeing what they do as opposed to exactly what's wrong in their brain specifically. So we have some pathophys. The physical diagnosis is not so much putting your hands on somebody as knowing how to ask the questions to figure out all the areas of information about that person to help you make diagnosis. So the psychiatric assessment is included under physical diagnosis because that's what you would do in the room with somebody. Now there are things you can do to people. There's movement disorders that are part of treatment. There are movement disorders that can be part of the problem, of the diagnosis. And some of these things you've already seen. That's why you can't forget what you've had in neuro, but you always have to do psychiatry after neuro because you have to have the structural, functional, known derangements here, and then we move over to those things that are not quite as understood, but they are still linked to brain function in some way. So there is, we'll see words today that you've seen for this test. And this will be as red hot as you're going to be about neuro, unless you become a neurology PA somewhere down the road. Okay. Also, pharmacotherapeutics. How do you treat the drugs? So we'll be looking at those big broad areas. The other terminology and prescriptions, y'all already know about that. I know the Dr. Latasi combined neuro and psych together, which actually makes good sense. So there is an assessment in that at the end of the week. So that's that Friday, 8 a.m. thing. And I don't think it's not going to last an hour. It's usually over with and done. And we will actually have class starting at 9. But that works, right? It should work. I know there's some of you trying to break the record. Keep asking, has anybody broken the record yet for how fast you take that test? And I think we're just now down to physical limitations. How fast can you write? How fast can your hand move? So it is possible, though, that somebody can beat that record. And I really would like to see that record beaten. I may actually cheat for y'all, so just to see what she says. Oh, I can do that test in 2 minutes. No big deal. So we'll see. All right. So those pieces will remain within the class. And then expansions of the learning objectives under the concentrations, you can read for yourself, but these also show up in the learning objectives as they apply to various disorders. These are kind of the broad overviews of things that we're looking at. Let me scroll down here a little bit more. Rolling. Okay. Learning outcomes for this class. Okay, after reading and studying course materials and participating in all the activities, you should be able to begin applying medical knowledge in the care of psychiatric patients. Hopefully that will be safe. You should be able to begin communicating effectively with psychiatric patients and applicable healthcare team with more knowledge. Understanding the healthcare system and its application of patient care for the psychiatric patient. We will talk about where people go, what can happen, what's out there, what's not out there. There will be resources that will grow about the system all along. You will begin exhibiting professionalism as it relates to psychiatric care. And there are things to talk about because when you're looking at people with psychiatric and behavioral disorders, they're obviously not acting like you normally act or would expect. And there's lots of bias and bigotry that can happen in the care of the psychiatric patient. So we have to understand what's there, what's happening, and how do you engage that. You will learn much more about that when you're in your rotation in terms of how to interact, because the only way to learn how to interact with anybody is to do it. Mess up and get a feel for it. But you will be prepared to begin doing that at a better level. So we have to get terminology on the table and how do things work and how do we act with those. Demonstrating appropriate care for psychiatric patients, be able to begin applying evidence-based medicine to patient care as it applies to therapies and things we know, and using motivational interviewing in situations that may benefit from SBIRT, which just stands for screening, brief intervention, referral to treatment. So that's the technique. Okay, how are you going to get graded? That's always a very important little piece. Okay. You're going to have 2 tests. Last year I did 1 test. It was a behemoth. It was along the neurology lines of today. But I've decided I want 2 tests in every course, and where there is not, if it's a 1-week course, you can't get 2 tests, but we need to have that plus some other way to assess learning so that it doesn't all just ride on one big extravaganza at the end of that week. So you'll have an exam next Monday, and you'll have a final, a second exam the Monday after that. So there will be 2 tests. Each of those will be weighted equally, so they'll be 45% each. And then 10% will go to the SBIRT activities, which we'll talk about. You will have interactions to a couple of sessions to do that. And the grading for the SBIRT activities, I haven't put my grading rubric together yet for a good reason. I usually have these things put out, but the SBIRT actually is part of a research grant from social work. University of Oklahoma School of Social Work approached this program almost 3 years ago if they would be a participating site. And basically they're teaching professional programs how to teach students to screen, do brief intervention, or refer to treatment with those foundational motivational skills. And this program agreed to do that. I did it when I was over at OU, and we're doing it over here now. It's a good thing, but they do assess you and they collect data from the SPs as part of their research project. So I don't really want to change the way the forms are so that when the SPs do it, they just know how to check it off. They've been doing it for a lot of programs around the metro area, so this is not unique. But I wanted to transition that sheet into a score for what you do, how you perform across the board, and I'm not quite satisfied with that yet. And the other piece is, this is the other operating principle. You will have 2 sessions, one on Wednesday of next week and one on Friday of next week. And I want the one on Friday to be weighted more heavily than the one on Wednesday, because that's kind of like doing it for the first time. And last year, people made huge improvements from the first time to the second time. So I want the grade to be more reflective of when you were more comfortable with it as opposed to when you're experimenting with it. And the grading is actually fairly easy because I don't want you worrying about making a grade. If you're worried about making a grade when you're talking to somebody, you don't act yourself. And I need you to act yourself and be willing to make a mistake. You have to be that free-flowing to do motivational interviewing. So the grading will be such that you don't have to really spend a lot of time thinking about making a grade so much as thinking about performing well. If you do that, then the grade follows. Okay? Trust me, it'll make sense. I'm not going to mess you up. And the grade scale is the same here as we've always had. Prescription writing and midterm are at the competency level that's been established before. So that's it. So it pretty much just runs on. All the rest of this are just the policies that happen. So any questions about the basic way you get a grade or what you're expected to do so far? I'm going to run through the schedule. We'll kind of look at it, and I'll talk about the rationale for that. Okay, that's that. Now, okay, here's our schedule, and there is a logic to this. Okay, today we're going to do the psychiatric assessment piece. You'll see words you've already seen in neuro, and you'll see some words that you have heard before, and you'll see some words you've never heard before in your life. And we'll look at those. And then we will start depressive disorders late this afternoon, finish that tomorrow, and then do bipolar disorders. And then we'll have therapy of depression and bipolar disorders. And that will get major sets of drugs on the table, which I actually have to have because so many of the other ones operate within these same medications. In the afternoon tomorrow, we have Karen Orsi coming. She is medical director for Oklahoma Mental Health and Aging Coalition. She does an excellent presentation on suicide, and you really have to talk about suicide when you talk about depression. And she also has a technique that she will teach you. Hers is called the QPR technique, which is question, persuade, and refer. So it's another way, how do you engage a person who is potentially suicidal? That's going to happen in practice, and you have to respond to it. There are some things you cannot hear from a patient and go home and do nothing about. You're liable. So she's going to talk about those types of things, and then that packages all of the mood disorders in the block before we get to the break. Okay, then we come back and then we move into the psychoses. So we'll be looking at schizophrenia spectrum and other psychotic disorders, and then we'll look at therapy, and that'll be an afternoon block. And then we'll have the major antidepressants and mood stabilizers and antipsychotic medications, major tranquilizers in the box. And we'll be almost there except for anxiolytics, the anxiety medications, which you already heard bits and pieces of about already. Okay, so we'll do that. Friday, we kind of move into some different things. I'll put elder abuse in really because I have to put it somewhere, and it fits relative to everything else. It's kind of a standalone topic, but it is something that you have to be familiar with as a PA. There also is a requirement that you understand child abuse, but that is being taught in the pediatric module. makes more sense to kind of confine the whole population together because a lot of the findings and things are unique to that group. Just like we teach ADHD in the pediatric module, I moved it out because there's kind of a spectrum of behavioral disorders that do better when you teach it, when you're teaching all children things at the same time. Okay, we also will have feeding and eating disorders. This, I haven't heard this person talk before, but we've used she works out of the same center. And OU has a feeding and disorder center. This is fascinating. And so she will come and do the presentation in the morning. And then in the afternoon, so that'll be Shauna Lawless in the morning. And then we'll have Kristen Colton will come and talk to us about obsessive compulsive and related disorders in the afternoon. And that's going to be interesting too. And then we will finish up our evidence-based medicine review of the triptans, which y'all turned in. And I apologize to you all many times over. I didn't like where it fell. It was scheduled the week before. It was scheduled not last week, but the week before. But Dr. Vanetta had to be out of town that week, and so it just forced everything too tight. Okay. I'll be kind to y'all when I grade that, and we will get out of here early enough on Friday that you can actually have a day as best we can get it. Okay. We pick back up on Monday with our first exam. It will not be 8 to 12. I anticipate this exam will probably be more like an hour and 15 minutes, you know, something along those lines. And I will schedule it later in the morning, but I don't ever really quite know where I'm going to lay it until all the questions, you know, go down. And we've done that, but it will not start at 8 a.m. for anybody, and we'll be done in plenty of time to kind of get ourselves refreshed. It will not be a neurology megathon. We're not doing that. It'll be more straight up. It will cover all the content that's been covered through Friday before that exam. So this week is the first test, and then the second week is the second test, and there's going to be a little bit of what we covered this week that I'm going to expect that you bring forward to the exam too, because I can't just have you just snip it out because there are drugs and uses that you have to keep remembering. Okay. If I could, I would, but it's not in the best interest of learning this stuff, so we're going to have to stay with some of it. But I will make it very clear what you need to know and how. Don't worry about it right now. Let's just worry about this week for this week, and next week I'll have enough troubles of its own. We'll figure it out when we get there. The afternoon after that test, the whole afternoon is really devoted to introducing the SBIRT process, motivational interviewing. There will be people here from the School of Social Work. It'll be teaching techniques, and you will actually practice the techniques with each other in the room. You need to do that. And some of you may have already had this and done it, maybe not, but I will tell you what, every time I do it, I still learn something else. It's one of those things that you're never done on. You don't do it, oh, I got it down. You never get it down. You just get better at doing it. So we'll do some things in the room, and then we'll go over all of what that activity is going to look like on Wednesday and Friday, and it will be good. Then it'll just be get ready to go do it. Tuesday is an all-day affair. We start out with anxiety disorders and then trauma and stressor-related disorders, things like PTSD, the phobias, all these kinds of things will happen. And then we will have personality disorders, my favorite topic of all. I love personality disorders. It's so good. I may just put up, I have a lot of video clips I may go, what is it? Who is it? Who are the people who've got that personality disorder? And I've been watching y'all for this first 6 months. I'm trying to figure out where they are. You look at the stats on personality disorders, it's not like 0.001% of the population. They all rate out at like 2 to 4%, 6%, 7%. So there will be some in here. It doesn't make you, and people might lean to something but not fully meet the diagnostic criteria. So we all have something about us. Okay. So don't worry. I'm not going to put your face up there and go, who is that? That's obsessive compulsive. And when you're a student, I think if you have obsessive compulsive, it starts to show up a little more because you have to do it to succeed. You have to have a pattern. It just shouldn't be pathologic. And then we'll have pharmacotherapy of anxiety, insomnia, and personality disorders to the extent that they can be treated with drugs. And all of them cannot. Most of them can't be. And I wouldn't even say you change a personality disorder, you actually just manage within what, you actually work with them on behavioral modification within their natural way of being. They can't help it. Wednesday is Good Shepherd Clinic. For those of you who are in Good Shepherd Clinic, I've got to double check this again with Monica. I don't want those who are in Good Shepherd to have to come out with the first blocks, but the SBIRT practice round 1 actually happens on Wednesday afternoon. It's a 25-minute session, 15 minutes of real-time interaction, 10 minutes of being given a critique, some verbal critique, and then you're gone. So your afternoon's not tied up all day with that. But you will have that, so I will double check to be sure that we give you enough breathing time that you come out of clinic and kind of gather yourself and then go do what you do. It's not such that you're at a disadvantage because you're in clinic. It just really is not. Just you'll have to see how it plays out before we get there, but it won't be that way. Or I wouldn't schedule it like that. And then Thursday, we have Amy Huffer's coming in talking about autism spectrum disorders. I really like that topic. That's a really good, interesting topic. And then I'm going to teach somatic symptom and related disorders. And then we'll have case discussions, and those may actually happen earlier if they happen at all. We have cases kind of built into the pharmacotherapy up to this point, and we'll see. If we get done what we want to get done, then that will be a free block. And if we haven't done all that we want to do, then we'll use that again just to help you actually think about using stuff. Usually, what happens in here is there's just this big throwdown, and then there's not time to actually work with it and use it. And then when you're studying, you're trying to figure out how you'd actually do something, and it would be more helpful, I think, if we actually just walked and talked our way through what we would do than having you try to figure this out in your room. It just doesn't work that way. And even if you did it that way and did fine, good, but there's still so many nuances to how people would actually respond to things that you just can't teach it straight up on a book. Okay, then Friday in the morning is the second SBIRT. You have your little slots done, and you will have a debrief session over lunch with the SBIRT people from the School of Social Work. So let's ask you questions, we'll talk, and we'll have food. We'll actually have food. And I'm thinking that we'll just do it right up here. We'll get it all managed somehow, or we'll do it over at Kramer. I'm not sure where they want to set up just yet, for their food. They get a vote. And then the only disaster of scheduling, and I cannot fix this, is your favorite faculty person. I've read the reviews. I've already seen the reviews. I know that did not go well. Okay, I know that. From some people's perspective. Is that a true statement? It was basically the let me tell you what's wrong with you, but you were not the people who did it wrong.
Yes.
Okay.
Yeah.
It was being chastised for others. And I would even say that it was fully appreciating all what was going on in the world beyond. So understand it. I read all of it. Okay? So I know that. But I will say this. I think that Professor Maskiel does a really good job. He is extremely knowledgeable, and he will do a good job. And we'll have interactions before, and we'll kind of get it to a good place. I'm going to ask y'all to be forgiving people and just let it all happen, and we'll see what we can do. The only thing I do not like that content falling on Friday. That bugs me. I really don't like that. It's not the way I would do it, but it's the only day. I mean, I would have had it done this Friday, so it was done. I can't get any other time, and there's a commitment from the program that he teach those topics for our students. So it's like, okay, well, this is it, but it's not the best. I will have objectives coming to you on Friday evening. I won't be done until I have that written out for you all to know, so that you know what to study. So all I will tell you to do in this class is study, take good advantage of your time that you have throughout that second week, and get ready for your test so that when you have new content, you won't just be thrown by that. And I will guide you to what to know, because he will present way more than what you need to know. It'll be good stuff, but if you're just left with that and walk out the door, you'll just be panicking. I'm just telling you, I have a panic quality to it. And we're not going to have that. Right? We'll get to 0 in. And that'll be that. And then we'll have a test on Monday, July 16th, and you will all pass this class. You will pass this class, expecting it. And you'll know something, and you'll be ready for the next class after that. Okay, so it'll be good. Any question about what we're doing, how it's gonna flow? I've apologized where I can for the stuff that I don't think is actually the best, but I think there's enough accommodations in how we're putting it together that you'll be able to do well. And you should have recovered fully by the time you get to exam 1, exam 2. So I think you'll do okay. Okay? All right. Let's get started here. Yes?
So tomorrow we have class till 3.
Yes. It'll be 3:30. It may be in sooner than that. She does. There's 2 presentations that she will do. She will do suicide as a topic, so she covers that. And I've never known a person who knew as much about suicide. This is awesome what she knows. She's just been so involved in it for so long. And then she will do the QPR technique, and it just depends on when she finishes that, because she will bring her presentation here, and she has a little booklet. She gives you some stuff to work with. I don't quite know, but it will be no longer than 3:30. That will be the end, but it could be a little bit sooner. Okay?
The calendar says 1.
Did it say, what does it say?
It says we're going through lunch and then till 1 and we're done.
Oh.
We got a little.
Yeah, there's
Is it going to be for an hour?
somebody keeps moving that stuff around. I saw, listen, actually, I saw that and I moved again, so I don't know why that is doing that. That is on the book for 1 to 3:30. She is like 10 to 12, and then that's 1 to 3:30. So that's how it's gonna be. It is. Thanks for asking that, but that raised a really interesting question because it has been moved, and now it just keeps doing it. Okay. I guess it can do what it wants to. Okay.